Hello, and welcome to the AMA's Steps Forward podcast series. We'll hear from healthcare leaders nationwide about real-world solutions to the challenges that practices are confronting today. Solutions that help put the joy back into medicine. AMA's Steps Forward program is open access and free to all at stepsforward.org.
Hello, and welcome to this episode in the AMA Steps Forward podcast series. This is your host, Dr. Kevin Hopkins. I'm a family medicine physician and a senior physician advisor here at the AMA. We probably all enjoy learning something new. To have a career in medicine, you kind of have to be committed to lifelong learning. And we also have to be honest. It's really hard to keep up. Experts tell us the current state is a doubling of medical knowledge every 72 days. Every 72 days. Back in 1980, it was every 7 years. In 1950, it was every 50 years. Even if we could absorb all the best knowledge, it's not exactly easy to actually put all the latest and greatest research and evidence-based recommendations into practice. Competing demands, inadequate resources, and leadership buy-in are all challenges to implementation in healthcare. So, how do we even begin to close the research to practice gap? To explore that question, I'm joined by our two guests. Dr. Mark Bauer is a professor of Psychiatry Emeritus at Harvard Medical School, and Dr. JoAnn Kirchner is the past director of the Veterans Healthcare Administration Behavioral Health Quality Enhancement Research Initiative, who's also on staff at Central Arkansas Veterans Healthcare System and a professor of psychiatry and behavioral sciences at the University of Arkansas for Medical Sciences. Dr. Bauer, Dr. Kirchner, thank you both for joining us on the podcast today.
Thank you for having me.
Pleasure to be here.
Before we get into how physicians and our teams can better translate research into practice, would you both mind telling our listeners a little bit about yourselves and your background and how you became interested in this? Let's start maybe with Dr. Kirchner and then you, Dr. Bauer.
Of course. So I am a psychiatrist by training, and for the majority of my career, I have focused on either researching or applying implementation science. I have led Query Quality Enhancement Research Initiative, or Query programs, supported by the VA for over a decade, and most recently stepped down to focus on education and mentoring.
And I'm a psychiatrist as well. I refer to myself as a recovering clinical trialist. And I have a very specific story as to how I got involved in implementation science. We had run a pair of randomized controlled trials using the chronic care model for bipolar disorder, an intervention that we had developed along the lines of Wagner and von Korf's chronic care model. And we had one randomized controlled trial running in the VA and another one in Group Health Cooperative of Puget Sound, now Kaiser Permanente. And it had 15 sites that were randomized to chronic care model or control. And we found that we had substantial improvements in our outcomes at little to no cost. But once the study finished, none of the sites adopted and incorporated the chronic care model into their practice. We had really no uptake sustained beyond the end of the clinical trial. And so this is a sign to me that it wasn't just evidence that you needed, but we needed to think in terms of other factors to determine whether or not something would get taken up into general clinical practice. And with that, I got my OJT degree in implementation science. That's on-the-job training.
I have a story similar to Mark's, but on a more individual basis. Very early in my career, I was part of a large multi-site, multi-investigator study, and we were looking at developing models to implement integrated mental health into primary care settings. I was working specifically in rural clinical practices. And there was this one practice where we had put the model in place and everything was looking good and no patients came. And I remember walking into my mentor's office in defeat, head low, miserable. I've failed. I have done everything I know to do, and I can't get this to work. And this very wise mentor, may everyone have a wise mentor in their life, this very wise mentor said, JoAnn, if you've done everything you know to do, then the most important question in your study may be, why couldn't you get this program up and running in this clinic? And that started a whole sub-investigation of understanding the why
Yeah, in medicine, we often ask why. Why did something work? Why did something not work? And understanding the why helps us oftentimes get to a better what. And so we'll talk about some of the barriers to implementation of new and exciting knowledge and information. I'm not sure if everybody's familiar with the term implementation science. So I assume that means, how to take something and actually put it into practice, operationalize it as part of your workflow. But I may be incorrect about that. Can you help me understand how you define implementation science?
Well, implementation science is a science akin to clinical science, but it focuses on barriers and facilitators to getting evidence-based practices into everyday use.
And so when we look in implementation science at what are these factors, these barriers and facilitators, we typically call them determinants. And so what are the determinants of uptake of a new clinical innovation? So rather than actually studying, again, the thing or the what, we're studying the how. So how do we increase the uptake of these clinical interventions into routine clinical care?
Thanks. That's very helpful. So you're both psychiatrists by training and background. Mark, I heard you say you're a recovering clinical trialist. I like that. Were you primarily researchers, primarily clinicians, or was it a mix of both?
Well, I started out as a clinician researcher doing basic science research and moved gradually into whole person clinical trials and then into implementation science. One of the most informative aspects of my career, though, for implementation science has been my time as an administrator when I ran a mental health service in the Providence VA and then was acting chief of staff of the hospital for a while. And that really was quite educational as to how systems really work. If you're a clinician, you're enmeshed in them and you don't really get your head above water. If you're a researcher, you're standing outside of them. But to be an administrator was to really have to understand how, at the system level, how care was given or not given.
I actually put as the first line on my medical school application that I want to go to medical school to do research in psychiatry. So I was a researcher out of the chute, but quickly became disenchanted with the almighty value of the P or the P value that tells us whether or not something works or not. And realized that there are a lot of things that work, but we're just not doing them. And that the experience I talked about earlier, supplemented with working with a clinical manager, much like, Mark was one, I was actually supporting one in a more research and evaluation role. This clinical manager had actually within the VA, a full region, managed 10 medical centers and multiple community-based outpatient clinics. As the VA was rolling out a standardization of the mental health care that was being delivered within VA, what I saw in supporting this clinical manager was that there was marked variation in the uptake of these recommendations across those 10 medical centers, and certainly within the VA community clinics, as opposed to the medical center-based clinics. What we saw was our highly academic affiliated, highly resourced medical centers. Well, they were doing great. Many of them were already delivering the standard of care that we were trying to implement. Whereas some of our small, rural located clinics and medical centers were really struggling. And that discrepancy helped me to turn away from effectiveness research and focus more on implementation science. Luckily, implementation science emerged about the time I got distracted, and it was a wonderful joining.
So what both of you said really helped me sort of frame it in my mind. And it just made me think about, Mark, I think it was you talking about as a clinician, you're kind of heads down, you're in the work, taking care of patients. You may not know all the great new research that's being done. As a researcher, you probably look at what you've accomplished and maybe what you've come up with as far as recommendations and think, well, why aren't the clinical folks using this? Why hasn't this been implemented already? Because it's so much better than what they're doing now. And maybe the sweet spot is sort of a blend of a clinician and administrator. I mentioned that's a big part of my role here in Cleveland. I help to oversee the Primary Care Institute from a clinical operations standpoint. And so a lot of that has to do with implementation and certainly change management has to be a big part of implementation science, right?
Certainly, we incorporate change management as one of the core components of implementation science, but we pull back and we take a little bit of a broader view. We typically apply implementation frameworks to look at those barriers and facilitators that Mark mentioned earlier that can impact uptake. And then on top of that, we apply the change management techniques as well as addressing the more systematic barriers that may exist within a healthcare system or at a clinic level or at an individual level.
And there's a lot of ways to come at implementation science and change management. There's a variety of frameworks, and one that we use because it's so simple and has such face validity is called IPARIS. And JoAnn, you can help me out because I can't remember what IPARIS stands for.
The Integrated Promoting Action on Research Implementation in Health Services, or IPARIS.
But the model is much simpler than the name. It says that successful implementation is a function of facilitation or change management, the characteristics of the innovation, characteristics of the recipients, and the characteristics of the context. Each of these domains can have barriers and facilitators, and change management or facilitation is what we really apply to analyze the barriers and facilitators in each of these domains, and then to help develop strategies to change them.
So we all probably know that establishing the effectiveness of a new innovation doesn't always guarantee that it's going to be accepted and implemented. So what are some of those barriers of taking a great idea and making it into a widely accepted standard of care?
Well, let's take a look at the great idea itself first, because there's a number of characteristics that have been known really since the 1960s that are going to affect whether something is taken up. And it's not all evidence. In fact, evidence may not be evidence in the way that we think of when we read journal articles. Evidence is local as well as clinical practice guidelines and the like. But it's really whether something will work or has worked in my individual setting. It's also the degree of fit of the innovation with the existing practice. Does it give a relative advantage over what I'm doing now? Business as usual is a pretty strong reason for continuing to do what you're doing. There's a certain inertia that comes with it. Trialability is another aspect. Can I try this out and discard it if it doesn't work, or do I have to sign on for a lifetime contract? And I want my results to be observable. So we could go back and take a look at our chronic care model for bipolar disorder and analyze it as a complex innovation that was hard to trial because you had to commit to doing it and you couldn't really back out of it. The results were observable, and the question was, did it give enough relative advantage to have people change their ways? Really, that was in the eye of the beholder.
So some of the things you mentioned, it just made me think about innovation in medical diagnostics and therapeutics, for example. So the new product or intervention or technique, it has to be at least as effective and safe as what's available now, right? It may have to be cheaper or otherwise more accessible to patients who might benefit from it. And it has to be scalable to meet or at least approximate potential demand, right? So those are a few of the barriers that would fit into the categories that you mentioned, Mark, sort of that degree of fit, the usability, trialability, and outcomes that are measurable and observable. So could you walk us through some of the implementation science that you're putting to work or your teams have been putting to work?
Well, as Mark mentioned earlier, the one that we in our practices have used most commonly has been IPARIS, but you've got to realize there are a lot of determinant frameworks. I love IPARIS because I can put it up on a slide trying to explain it to a clinical manager, and they can understand that when we look at the determinants or the barriers and facilitators to implementing a program or practice, there are determinants associated with the innovation itself, the program or practice, as Mark explained, as well as the context within which you are implementing. So the local or inner context, as well as the outer context, the policies, the drivers that may be associated with implementing the program or practice. Couple that with the individuals who will either be providing the practice or who may be receiving the practice, or as IPARIS would say, the recipients. And these domains do not work independently. They influence each other and ultimately influence successful implementation. And I would be pretty daunted if our colleagues Allison Kitson and Jill Harvey had left us there. But they actually added a process or the change management technique that we talked about earlier of facilitation. And facilitation then is the process of helping and enabling a system, the recipients, to adapt the innovation so that it functions and is successfully implemented and sustained in their clinical context.
I can give a little example of this. We never let our chronic care interest die away. And subsequently, we did a meta-analysis of all the controlled trials of looking at chronic care model application to mental health conditions and found that there was strong evidence that it worked across conditions. And the leadership in mental health at the VA nationally came to us and said, we saw your meta-analysis and we want to start to implement the chronic care model as our go-to framework in outpatient clinics for general mental health. And so we partnered with the VA healthcare system, setting the internal context to support the change over to this model. We used a detailed facilitation guide that JoAnn helped us to develop, and then ended up having us work with very local contexts with recipients to match the chronic care model to their needs and fit with their local priorities. We were able to successfully implement the chronic care model in the majority of sites that we had done facilitation with.
I'm just wondering if you can paint a picture for us about just how big the research to practice gap is in healthcare.
A couple of studies have shown that it takes between 17 and 20 years to get an evidence-based practice into general clinical usage. About half of them don't even make it ever into clinical usage. And some people have calculated that the return on investment of the dollar is about a dime in terms of public health impact. So we're spending 10 times as much as we're actually getting benefit from.
Yeah, to me, that is very striking when you're talking about a decade at least, or probably two, to get something that's been proven in the research lab actually to the bedside or to the clinic. And when you think about that, the care that we're giving to patients today is based on innovation and steps forward that is 20 years old. And so we talk about and want to be at the cutting edge of innovation. And yet, just by nature of the field in which we work, we're really not. I always just kind of thought and assumed that was because a lot of people in medicine practice based on how they were trained and when they were trained. And we were learning so much new information during that stage of our careers that it really impacted the rest of our careers. And so, but maybe it's not just that. This might be an impossible question to answer, but where do you think the biggest limitation or barrier is? Is it in gathering and attaining new knowledge, sharing that knowledge? Is it acceptance, readiness for change, or are there really operational components? Where do you think the biggest bottleneck is?
How about all of the above?
I somehow just knew you were going to say.
Because any one of those determinants that you mentioned could be the rate limiting step given one context, one group of recipients, and one innovation. And it's the variability that makes it so challenging in such exciting work. It may be access to knowledge in a very small, isolated rural clinic. It may be organizational change in a highly structured healthcare system. So all of these factors interplay. And by systematically assessing them, using an implementation framework, we can identify those factors, match them to the strategies that can address the barriers, maximize the facilitators, and ultimately lead to successful implementation and uptake of all those wonderful practices that are rolling out from our clinical science friends.
So what would you tell to a physician who's listening to this podcast who maybe is in a small private practice with a couple of partners, or maybe they're in a large academic medical center with lots of different physician and APP colleagues in their practice, who thinks about, gosh, you know what, I just read about this in a journal. It sounds like this is something that we ought to be doing now, but we're not set up to do it. What would you tell them as far as a stepwise approach to think about taking something you read about and getting it to implementation at the bedside, even just for my own practice? How would you encourage them?
I think one of the first steps you want to do is talk to your leadership and get leadership on board, because if they don't back it, nothing will happen. And we've seen that time and again with well-meaning clinicians trying to do the right thing without engaging leadership. There's really no institutionalization of the change. And as JoAnn says, to allocate the time, there is going to be a cost here. But the change management is going to take time, and it's going to take trial and error. It's going to take data collection. But if you start on a small scale and scale up, you can usually be successful.
I think I would start by just acknowledging the situation, that change is hard, but you are not alone. And then I would couple that with understanding that you need to allocate the resources. Now, whether that resource is time, whether it is identifying someone to support implementation, but that you allocate the resources necessary to implement and perhaps most importantly, sustain.
I think that's a really important point, JoAnn, because initiatives, anything that we try to undertake that is under-resourced is just doomed to fail from the beginning. And everything has an opportunity cost, right? But just by nature, if we're going to start doing something, we probably need to let something else go. And that can be difficult decisions, especially for us that work in healthcare who are just used to adding and piling on. What can we let go of and set aside in favor of something else?
And there's actually a whole field of implementation science that's focused on de-implementation. So that actual letting go of either ineffective or outdated, or sometimes, unfortunately, even harmful practices, so that you can allow the time for the new, currently evidence-based practices to emerge.
Absolutely. That's a really great plug for our AMA Steps Forward de-implementation checklist. Thank you for leading us down that path. I really appreciate it. So thinking about how we can stop or at least reduce lower value and even potentially unnecessary or harmful work, and how we can better delegate the higher value necessary work to take care of our patients across a team. It's really essential for sustainability and something we all should be looking to address. Well, thank you so much, Dr. Mark Bauer from Harvard Medical School and Dr. JoAnn Kirchner from the Central Arkansas Veterans Healthcare System and the University of Arkansas for Medical Sciences have been our guests today. Thank you both so much for sharing with us the important work you've undertaken to advance innovation from the research lab to the clinic and the bedside. Thank you all for listening. Until next time, stay well.
Thank you for listening to this episode from the AMA's Steps Forward podcast series. AMA's Steps Forward program is open access and free to all at stepsforward.org. Steps Forward can help put the joy back into medicine by offering real-world solutions to the challenges that your practice is confronting today. We look forward to you joining us next time on the AMA's Steps Forward podcast series. stepsforward.org.